Okay, so this is what you do with any lung nodule that you find. One of four things: leave alone, follow up, biopsy, or resect. When do you leave alone a lesion? When there's no change in 2 years, when it's completely calcified, less than 6 millimeters in size, without a known primary or a high risk status, and a definite juxtapleural or periphyseal nodule. So, something like this, no change in 2 years, completely calcified, you will leave alone and not do anything about. But what about this? You've got a 4.6 millimeter nodule, right middle lobe. She's had CA vaginal vault. This was a surveillance CT. What do you do with this? Can you leave this alone as well? When you see a nodule, right, you have to look at it in three planes. And when you look at this in three planes and you see the SAG image and it's ovoid, you know that this is what we call a periphyseal or juxtapleural nodule, and it can be easily left alone. Nevertheless, and these are the criteria for a PFN or juxtapleural nodule. In this case, because there was a malignancy, they still wanted to follow up, and you see that there's absolutely no change over 3.5 to 4 months. So we were right in perhaps saying that nothing further needs to be done. So those are the lesions you leave alone, right? Completely calcified, no change in 2 years, etc. Then there are lesions we follow up, and that depends on whether they are solid nodules or subsolid nodules. For solid nodules, the period can vary from 12 weeks to 1 year. For subsolid nodules, the period can vary from 12 weeks to 9 years, right? That depends. What is extremely important is what we call nodology, or measuring the nodule accurately, which is something radiologists hate to do, and which is where sometimes patients get into trouble. So if you have an 8 to 15 millimeter solid nodule, no prior imaging, and if it's rounded. Now, if it's ovoid and juxtapleural, even up to 12 millimeters, you can leave it alone. But otherwise, if you have any nodule with these criteria, you can follow up these patients. For a subsolid nodule, you will always follow up at 3 months. That's the first thing you do when you see a subsolid nodule. So here's a 61-year-old incidentally detected nodule on a CT chest, irregular margins, little bit of a ground glass halo, was advised a follow-up at 1 year, came a year later, casually reported by a very good radiologist, no change. And if it's no change, then you'll wait another year, right? Or 2 years, or forget about it. Patient came for an opinion, and I'm a little obsessive about measurements. So we measured. And when I measured at the same level, using the same parameters, you find that there is a 6.4% increase in size, which even held up in the superior-inferior plane. So you've got progression in all three planes. So we biopsied it, and this is an adenocarcinoma. So the point being that you need to follow up, but when you follow up, you also need to make sure you do the right measurements for the nodules to know whether they are progressing, whether they are stable, or whether they've regressed. As in this patient, carcinoma breast, subsolid nodule, what do? Always wait for 3 months. You don't do anything with a subsolid nodule the first time, and 5 months later, everything's gone away, so you didn't have to do anything further. Then you have the third option, and that is to biopsy. So now we're talking of nodules that come to you the first time, right? What do? Do you leave alone? Do you follow up? And here we're talking of biopsy, and the next we'll talk about is resection. So which ones do you biopsy right away? Solid nodules and subsolid nodules. Solid nodules greater than 15 millimeters at the first instance. Sometimes 10 to 15 millimeters of high risk. Any growing nodule and any new nodule on follow-up. If you have a subsolid nodule that's growing, then you may biopsy it. But if you have a part solid component greater than 8 millimeters at the first instance, then you biopsy it. And obviously you can biopsy a growing nodule. So 62 years old man, 25 pack years history, 8.8 millimeter nodule. We use the Lung-RADS criteria. It's greater than 8, less than 15. So the next thing you do is a 3-month follow-up. At 3 months, the nodule increased in size, so then you have to biopsy it. So this comes under the category of growing nodule, therefore it has to be biopsied, and this was adenocarcinoma. Now this is a 22 pack years history smoker, has a 16.4 millimeter nodule, which is greater than 15 millimeters, which means you biopsy it right away, which is what we did. It turned out to be tuberculosis. Now this is a 11.5 millimeter nodule in a 20 pack years history smoker. It fits between 8 and 15 millimeters. You could argue that I would want to do a 3 months follow-up, but it's got spiculated margins, it has a knot sign, it has features that morphologically are high risk for malignancy. So in this case, we did a PET CT, it showed uptake, went ahead and biopsied it. It has an adenocarcinoma. With subsolid nodules, as I said, if you have a part solid component, that's the part solid component of this subsolid nodule. If it's greater than 8 millimeters, you would biopsy it right away. Now this is greater than 5 millimeters. The patient was a doctor, didn't want to wait, didn't want a 3 months follow-up, insisted on a biopsy. So then we went ahead and did it. And this was an adenocarcinoma with lipidic spread. Now, if you'd waited for 3 months, that would have been fine as well, because the growth of these lesions is so slow that it wouldn't make a difference to prognosis and follow-up. Now, these were all smokers. This is a 54-year-old lady, non-smoker, had a COVID CT done, and this nodule was found. We waited for 3 months because it's 11 millimeter nodule. I said nothing to be done. Comes back 4 months later, and there's an 8.2 millimeters or an 8.2% increase in size. Now, again, this only works if you measure accurately at the same level in the same manner. If you're going to eyeball this, you're going to say that there is no change. This was also there in the superior-inferior plane, so we went ahead and biopsied it, and this is a pulmonary sclerosing pneumocytoma. You can also look at nodules as growing, non-growing, and if it's growing, you have 3 options: biopsy, resection, and active surveillance. And here I've listed the various points that you need to look at that helps you decide what other things to do. So then let's move on to resection. When do you resect a nodule without a biopsy? For a solid nodule, if it's a patient below 50, peribronchial, smooth margins, DOTA positive, and no spread anywhere else, you don't need to biopsy a neuroendocrine tumor. You can resect it right away. Also, an obviously metastatic nodule in a patient with a primary neoplasm that is known to commonly have lung mets. You have a CA rectosigmoid with a lung nodule, looks metastatic, you could just go ahead and resect it. Subsolid nodules that are growing with no spread anywhere, you need not biopsy. So here's this 54-year-old. We had radiographs from 2007, and you can see how it's been growing from 18 to 22. The CT showed a well-defined smooth nodule obstructing this bronchus with a bronchocele. The nodule is only this much. This looks like a carcinoid. Did a DOTA. DOTA is strongly positive, no spread anywhere, and I recommended that you just remove it. You don't need to do a biopsy. So it was resected, and it turned out to be a neuroendocrine tumor. You can do the same with subsolid lesions. Now here is this subsolid nodule at presentation. Again, this was a COVID CT. You can see it's grows another 4 months later. This was at the time when the PET CT was done, and this is 4 months later. So at over 11 months, there's a 20% increase. The PET didn't show anything anywhere else. There's a knot sign. This is a classic adenocarcinoma. This was resected without a biopsy. So for radiologists, always have the Fleischner Society guidelines with you to help you. And for smokers, have the LungRADS 2022 criteria available for you to look at, and then you can follow the guidelines. But basically, when we see a lung nodule, when we're reading scans, we have to think and ask ourselves, what should we do with this nodule? And you have to categorically write that down in the report. Leave alone follow-up, biopsy, or resect. This is my book. I always plug it wherever I am. It's a non-radiology book. Thank you so much for listening to me.